It's time for the next session. Do you know the diagnosis? To test our knowledge and everything that we learned so far. So I would like to present to you a few cases of the most difficult diagnoses, and I think that we will learn at the end that you will feel more comfortable making them. So this patient was referred for their fetal echocardiogram and genetic counseling because of the family history of congenital heart disease. Prior child was born with Marfan syndrome. So, as you know, this is most of the time we cannot see much on the Marfan syndrome babies in utero. So, but we followed the protocol and we're doing the assessment of the heart according to the traditional echo standards. So this is the 4-chamber view. Baby is in the cephalic position. So how does it look for you? Normal or abnormal? Abnormal. So what's abnormal? So the left atrium has this kind of very elongated the atrial appendage that looks very unusual. And also I would like to highlight that the posterior wall of that left atrium is very bald. So then we change the angle of scanning a little bit and we can see more details. You can see that here is behind is the linear structure, and this linear structure most likely vascular. So what do we do next? We put color on, we are trying to connect that vascular structure, and it seems, very misleading because it looks like it's basically connected to the left atrium. So, but we are following our protocols. We apply spectrodoppler to Doppler at least one pulmonary vein on each side. And this is the pattern of the blood flow. Definitely abnormal, looks monophasic, doesn't resemble the triphasic normal appearance that is typical for the normal pulmonary veins. Well, what can we do next? We look at the same structures from the different angle or different position of the baby and trying to confirm if this is abnormal finding or not. So here we have the axial orientation of the 4-chamber view. We can clearly visualize the pulmonary veins, as Tracy highlighted for us that this is the best position of the heart for the assessment of the valves. Do we have more confidence that the pulmonary veins drain normally or not? Probably not. So then we use the more sensitive technique for visualization of the smaller vessels, that for microvasculature. Is there any help here? Probably not. But the spectrodoppler definitely demonstrates abnormal blood flow. So at this point, we already have some concern that those pulmonary veins are not getting back to the left atrium normally. So the next question that we need to answer, where they are connected to. So we are looking at the 3-vessel and trachea view here, so you can see clearly that it demonstrates 4 vessels. So we have 2 great vessels normally connected to each other, normal relationship to the trachea, normal size. We can see the SVC on the right place. And here we have something that looks like the persistent LSVC, or at least the same image that we can see on the right. So, but going further up to the upper mediastinum, we also can visualize the thymus, and we can see the posterior border of the thymus, which is the brachiocephalic vein. So based on the general knowledge, if you have the persistent LSVC and if you interpret this vessel as persistent LSVC, you should not be able to see the brachiocephalic vein. It's usually absent. So we will add color on, and we can see that that brachiocephalic is not absent, it's there, and it's dilated, and it shows the significant blood flow. So at this point, we can conclude that this is the total anomalous pulmonary venous return, and this is supracardiac type. So that vessel that we can see right here, it's not the persistent LSVC, this is a vertical vein that brings all that pulmonary veins blood flow up and drains it to the superior vena cava through the brachiocephalic vein. So I just want to highlight, we used basically just 2 standard screening views to make that very difficult diagnosis. So the next, and this is the confirmation, it was confirmed after birth. And so we are moving to the next case. That patient came to us with a suspected cardiac anomaly. And for sure, that was a pretty abnormal 4-chamber view. We can see here just 3 chambers in the heart, the left atrium, the right atrium, the tricuspid valve, and the right ventricle. Typical example of the hypoplastic left heart syndrome. So, but what we are looking at, we are looking at the venous return, and we can see very clearly that the right pulmonary veins are connected to the left atrium. How about the left ones? Well, not so much, right? And this is why we need to follow the guidelines and find at least one pulmonary vein on each side draining to the left atrium. Well, so we are not sure. We want to try all our techniques. Maybe that regular color is not sensitive enough to demonstrate that, so that we can see here that even the very sensitive technique that allows assessment of microvasculature shows that these left pulmonary veins are not going to the left atrium. So we can see the typical blood flow in the pulmonary veins on the right. Typical for hypoplastic left heart syndrome, that's some degree of the restriction of the foramen valley. So what do we want to do next? We need to find where the left pulmonary veins are going. Well, our next favorite view for assessment of the heart is the 3-vessel and trachea view. So what we can see here, so this is the video clip, and this is 2 frames retrieved from it at the level of the 3-vessel trachea view and at the upper level where we can see the brachiocephalic. So we can clearly visualized in this case that there is discrepancy in size, that the pulmonary artery being much bigger than the aorta. So the aortic isthmus is not very easy to visualize using the grayscale imaging. Again, we can see the superior vena cava, and then we can see the symmetric vessel in the same view that, again, we need to interpret very carefully. Color is our friend. We can see the confirmation that this is typical picture of the hypoplastic left heart syndrome, that the reverse filling of the aortic arch, because in this case we deal with the aortic atresia. But also we can clearly visualize the direction of the blood flow in these 2 SVCs, right, in the different directions. So this is the typical SVC. It flows towards the heart, and this is a vertical vein that drains the left pulmonary veins. Again, supracardiac anomalous venous return in this case is just partial, because only left pulmonary veins, and this is on the sagittal plane, we can see how the left pulmonary veins forming that vertical vein that drains to the brachiocephalic and then to the SVC. And this is also what was confirmed postnatally, and that was the partial anomalous pulmonary venous return in association with the hypoplastic left heart syndrome. So here I would like to demonstrate and kind of highlight the differential diagnosis. Then you have this finding, that symmetric circular structure observed in the level of the 3-vessel and trachea view. Based on the incidence of the persistent left superior vena cava, so that's going to be the majority of cases that you're going to see seeing this appearance of the 3-vessel and trachea view, they're going to represent the persistent LSVC. But in order to make sure that this is this diagnosis, you need to take a look above and below the 3-vessel and trachea view. In the settings of the persistent LSVC, if you look at the superior mediastinum, you will be able to demonstrate no evidence of the brachiocephalic vein. If you look at the level of the 4-chamber view, you will be able to demonstrate the circular structure that is adjacent to the lateral aspect of the mitral valve, annulus. And if you slide even further down towards the diaphragm, you will be able to recognize the dilated coronary sinus. If you have supracardiac total anomalous venous return or partial venous return as the last case, you will be able to see at the level above the 3-vessel and trachea view the very, very dilated brachiocephalic vein, or at least you will recognize the brachiocephalic vein there. You will have difficulties to find the drainage of the pulmonary veins to the left atrium, and the coronary sinus will be normal. So the next case, we have here the patient who had no prenatal care, showed that Friday afternoon, 5:30. I remember that very vividly because I basically checked out. I was already thinking about my kid's birthday. I was like in a different mood, as you can imagine, at that time of the day. So, and this is the screening views that we are using. The patient was referred for the fetal echocardiogram, some suspected malformations, but basically it's not that unusual to see such a discrepancy in size. Then the right side of the heart is a little bit bigger than the left, and this is what's very commonly observed at the late third trimester. I want you to take a moment and take a look at this abdominal circumference and see if you see any abnormality here. But let's move on because, the diagnosis is coming. So how does it look for you here? Do you think that this pulmonary vein is connected to the heart normally or not? Yes or no? Yes, right? I thought that too. Quite difficult visualization, 34 weeks gestation. Okay, so this is a little bit discrepancy. It's because it's late third trimester. Move on. Yes? No? We need to get the spectrodoppler of the pulmonary veins. This is how it looked. And this is where you put the probe down and thinking, goodness, I'm not going home anytime soon. So because the spectrodoppler demonstrates, the pulse wave demonstrates very abnormal appearance of the pattern of the blood flow, and this is something that indicates right away that those pulmonary veins, they're not connected to the left atrium, they're not showing that typical pattern of the blood flow, and that they basically demonstrate that this is connection to the systemic circulation. So, and for sure enough that if you change a little bit angle of scanning, then you already have the suspicion then that you have no problem to find that collector, and this is confluence of the veins, is actually behind the left atrium. And now you're pretty confident that, well, they are not connected. But if baby is in such good position and, makes a beautiful turn for you, this is where you can see that, well, this is definitely an issue. But I want to attract your attention back to the abdomen, and this is where your fetal echocardiogram and the fetal cardiac assessment is supposed to start. If you look at the position of the aorta, this is inferior vena cava, and this is the other structure. This structure should not be there. So that's why then we look at the anatomical landmarks at the abdominal circumference. We need to confirm not only the things that should be there, but also note what looks unusual, what is additional structures. So then we apply color, and we can see it's vascular. Then we can take a look even more, and we can see the direction of the blood flow in the descending aorta and in this vessel is the same. So that means that the blood flow direction in this vascular structure is away from the heart. And then you can actually change the angle of scanning, and this is where you connect that vascular structure back to the chest. And of course, if you obtain the coronal plane, which is under no circumstances is our typical plane for fetal echocardiography or for the cardiac screening, here we can clearly visualize that the pulmonary veins from the right lung and the left lung, they form the confluence, and then the vertical vein that drains all those blood, the circulation from the lungs, down to the portal vein. So that the final diagnosis here is the total anomalous pulmonary venous return, the some obstruction to infracardiac to the portal vein. Okay, and we have 1 minute left, so I would like to show you another case and how tricky sometimes it could be. So this patient was referred for fetal echocardiogram at late gestation, to the growth restriction, to the history of 2 preterm labor, and also we suspected the coarctation. This is the 4-chamber view, typical for coarctation, correct? We have discrepancy that the left side being smaller than the right. So then we took our measurements. Well, the mitral annulus measuring small, so typical. Then we have the blood flow assessment across the AV valves. We are looking at those chambers. Well, we are pretty convinced it's coarctation. It's even more convincing because we can see the hypoplasia of the isthmus and we can see reverse flow in the aortic isthmus. Now let's pause for a second and think why you can see the discrepancy in the size of the heart of the left and right chambers. You can observe that just in the growth restriction alone, but also you can see that in the other pathologies, and then you have the combination of the growth restriction and you can also visualize the reverse flow in the aortic isthmus, because that would be due to the remodeling of the cardiovascular of the system and adaptation to the hypoxemia that occur in the growth restriction. So let's go back to our 4-chamber view. What we forgot to look at, this is the area behind the left atrium. And here we, on the OB preset, that the PRF being 1.5, and we still cannot see the pulmonary veins. There we go. And not surprising that we can find them, but much lower. We can see the typical blood flow in there. And that is the other case of the infracardiac total anomalies pulmonary venous return. So they may manifest the discrepancy in the level of the 4-chamber view. Sometimes it's more obvious, sometimes not, but this always needs to be in the differential diagnosis. Then you evaluate the heart in the 3rd trimester, in particular than the patient said for the aortic coarctation evaluation. I would like to stop here. And thank you very much for your attention.